this morning it's my pleasure to introduce, I'd say our guest speaker, except our speaker is a faculty member here. So it's my pleasure to introduce Dr. Aryeh Shander. And I met Aryeh when I run a big cardiopulmonary bypass meeting, and we invited him as a speaker. And then I found out he was actually on the faculty at Sinai, and absolutely phenomenal talk. So I said, geez, can we get you over here for one of our Wednesday conferences? And Aryeh is now, you can see from his title, is both Chief of Anesthesiology, Chief of Critical Care, Hyperbaric Medicine at Englewood Hospital, and also runs the blood conservation group there. And, I was going to introduce Aryeh as kind of what he really does, and, a lot of the committees and things he's been on. But, first of all, he's took a residency in internal medicine and is boarded in medicine, boarded in critical care, then did an anesthesiology residency. So, triple boards in that, then hyperbaric medicine. And then I looked at the organizations, and every single organization that has to do with blood, he has either been a founding member and or an officer of. So internationally recognized for blood conservation. And, this year in cardiovascular surgery, one of our top 2 initiatives is to deal with blood conservation. So we decided to get a group to help us do that, and to kick it off by inviting Aryeh to give a talk relating to cardiac surgery and blood conservation. And Aryeh is incredibly well published in the field of blood conservation and presents all over the world in topics related to that. So it's a real pleasure to have Aryeh both as a faculty member here at Sinai and to talk this morning at our grand rounds. So, Aryeh?
Julie, thank you very much. Good morning, everyone. It's certainly a pleasure and honor being here this morning. And as you could see, I've chosen the topic of transfusion overuse to start you off, because this is going to be mostly, I guess, a little bit provocative, but mostly an address of overview of why blood conservation is the route that we're all taking at this point, but probably giving you some reasons why and where we think we're going to be going in the future. So I'll start off quickly with disclosures, and then give you what I think is a salient way of looking at this conversation this morning, and that is talk a little bit about transfusion as a therapy. The problem is that this is the only area in medicine where we ignore the medical model. Generally, we like to identify a disease and then the therapy. When it comes to transfusion medicine, you're identifying the therapy and actually ignoring, in many ways, the disease. So I think we have to change this paradigm, if you will, and I think that one of the things that we're doing is, you see on this slide as PBM, which is patient blood management. We're moving from the product to the patient again, going back to the medical model of disease and the appropriate therapy for that disease. This leads us to the issue that we're facing, which is transfusion overuse. This is a global issue. It's not just a U.S. issue, but we've addressed this in the United States starting in 2011, and have had some very good results across the nation. But again, we'd like to see outcomes related to what we do when we change what we, either paradigm or the therapeutic interventions that we have. So I'll talk about the prevalence and the consequences of transfusion overuse, and then move to the fact that transfusion, although is something that we do almost every day, and it's a very common procedure done in hospitalized patients, the science behind that is lacking. And we're still looking and asking the same questions over and over again over the last few decades without getting any answers, but that doesn't stop us from spending an enormous amount of money and, again, trying to answer questions that we probably should not be asking, and ignoring the questions that I think we should be asked. So this leads us to the sort of the yin and yang of transfusion medicine. Everybody wants to know when to transfuse the patient, and I'll go through some of that. I'll leave you, though, with patient blood management, which is the new paradigm, as I mentioned, moving from product to the patient, and who knows what the future has, especially in this election year. So transfusion is a therapy, and I'm concentrating mostly on red cells, but keep in mind that you can extend this to plasma, you can extend it to platelets and cryoprecipitate, which, by the way, doesn't exist in every country, so you're going to see some geographical changes. But red cells are the low-lying fruit. So what's the disease for red cells? We all know what it is, and I'll digress a little bit to tell you a little about this condition. Some will argue is not a disease, but while we're arguing whether it's a condition or disease, it really doesn't matter because, again, the approach is through the medical model. Globally, anemia affects close to 2 billion people. It's a quarter of the world population is anemic. It's the highest prevalence is in preschool children, as you can see, about 50%. The group with the greatest number of individuals affected are non-pregnant women, close to 500 million across the globe. So by definition, as you're looking at this is an epidemic. It's an epidemic which has not just in terms of numbers, but has consequences in terms of burden of disease. So we're not only looking in terms of morbidity and mortality, but looking also at life with disability. I'm just showing you this slide. I don't have a lot of time to go through this, but just to show you that this is a calculation that we do now for diabetes, for heart disease, cancer, and any other disease that affects us on a population level. And lo and behold, anemia has about 68.36 million years of life with disability. Again, 8.8% of total of all conditions globally. This is not much different than some of the diseases that we pour an enormous amount of work, research, and try to improve, such as diabetes, cancer, and others. But the problem is that anemia is just not a sexy condition. And we've been living with this for quite a while, where we still have arguments amongst ourselves, well, the hemoglobin is X, Y, and Z, it's not so bad, or this has been a chronic condition for a patient. We don't do it with other diseases. We, again, attend to them in the medical model. So we've stated for quite a while that anemia is often accepted, or actually most of the time ignored. There's been a very long tradition of accepting anemia as a harmless problem that can be easily corrected with transfusion. We only offer transfusion for hospitalized patients. We do not offer other modalities which may actually have better outcome at lower risk to patients. For the medical community, transfusion as a treatment of anemia remains the default, again, especially for hospitalized patients. And now we understand that anemia is an independent risk for morbidity and mortality, regardless of the level of hemoglobin. Even small decrements, we're not talking about hemoglobins of 5. We're talking about small decrements of reduction in hemoglobin from normal, or the underlying disease, whether you have cardiovascular disease, whether you have cancer, or whether you have diabetes. It really does not matter in terms of, again, the response that we have. And the independent risk of anemia goes across the board. The problem is there's nobody to defend or attack this problem. We have lost our colleagues in hematology to oncology, so it's very difficult to find someone, although we have in this institution, it's very hard to find someone who is an anemologist, someone who can actually address this, because many of our colleagues in oncology do not know some of the epidemiology of anemia today and what is available for both the diagnosis and treatment. One of the areas that is now being concerned with across the US and in Europe, I think Australia has moved in also, is this phenomenon called hospital-acquired anemia. This is a publication in Hospital Medicine, came from the Cleveland Clinic, from, again, some of you may know Colleen Koch is now at Hopkins. But looking at their 10 hospitals, you can see it's a large number of hospitalization, close to 200,000. And they divided their groups into mild, moderate, and severe anemic patients. So again, you could see that hospital-acquired anemia occurs approximately in 3 out of 4 patients. And when you're admitted to a hospital with anemia, the likelihood is that you're going to be discharged with worse hemoglobin than you came in, unless therapy is instituted, and we don't mean necessarily transfusion. It all depends on what the cause of the anemia is. Mortality, relative risk, as well as the lengths of stay and charges, as you could see, are all increased, but at the same time, mild anemia still has an imprint compared to the severe anemia. So just to give you sort of the understanding in terms of approach to this phenomena of transfusion through the disease, we need to identify the disease. It's very easy to diagnose anemia. I'll leave you with that. I'm not going to get into a lot of details. It's a very easy condition to diagnose, a disease to diagnose. It's even easier to treat in many ways, depending on the etiology. And lastly, the results of treatment of this particular condition are phenomenal. 9 out of 10 patients will be cured. Most of the time we have treatments. This is a cure. It's a completely different way of looking at this condition. So from this digression, let me go back to the issue of overuse, the prevalence and consequences. So in medicine, if we can lump things together, we look at things from a clinical point of view as well as from an administrative point of view. Administrative usually is government and regulatory agencies. So when you look at transfusion as a whole in terms of what's been published in the literature, outcome of patients who've been transfused compared to cohorts that have not been transfused is worse. Survival is shorter in this population, and well-being of patients, you feel a little better after a transfusion of red cells, is very short-lived. Those of you who have any association with transfused patients or chronically transfused patients because of bone marrow failure know that they have to come in for a transfusion usually every 10 to 12 days because a unit of blood that you get from the blood bank does not last long, regardless of the other issues associated with it. So again, this is a continuous, expensive, high risk, if you will, a therapeutic intervention, but there are some patients, again, we have no question are going to need it. But as I mentioned, it is short term. On the administrative side, if you look at this, cost of transfusion is high. And I think that it's now being recognized that this is a significant financial burden for institution. And the reason I say that is because of the behavior that we have, the issue of overuse, which I'll address with you in a minute. The efficacy has never been really tested in any way. The saying today is that if blood came to the FDA for approval, it will never pass the muster that we do for any other intervention or therapeutic modality that we have, because we don't look at risk-benefit and when we talk about transfusion, because we have never measured truly the benefit, and the risks, again, are concentrated on what can be transmitted through a transfusion rather than long-term outcome, which is I mentioned already. We spend as a country, and most of the Western world spends enormous amount of money on making blood safe. First rule is that blood will never, ever be completely safe because it's a biologic system, and each time a new agent gets into it or if infects it, we are again faced with the transmission of this agent and then the disease or outcomes associated with that. Whether it was HIV in the 70s and 80s or hepatitis C at that time, a West Nile virus in the 90s and 2000, and now Zika is visiting, and we've had SARS, it's always going to be an issue. So we have something called the principle of making blood safe, where we don't spare any amount of money to test blood, if you will, which is clearly rational, and it's a societal decision. But in fact, we spend zero money on prevention of this particular therapy or in other modalities to try to, again, even the scale. So in 2011, these two organizations, the AMA and the Joint Commission, this is not endorsement for either, got together and decided to look at something called overuse in healthcare. And just to give you an idea very quickly, the definition came out in 1980 from the Institute of Medicine, looking at the use of health services in circumstances where the likelihood of benefit is negligible, and therefore the patient faces only the risk of harm. And going back to the decision, there were 5 areas selected. There's no priority amongst them. Elective percutaneous coronary intervention, myringotomy in tubes, early cesarean section, and I don't know how many of you in the audience have finished your Z-Pak, but you could see antimicrobial for upper respiratory infection, most are viral, and we're now suffering the consequences of selecting out bacterials that, or bacterial species, which again are resistant to many of these antimicrobials. And lo and behold, blood transfusion, as you see on it. Again, this was a committee that then created these task force. And being on the blood transfusion task force, we had to ask the question, is there any data to support overuse of transfusion to start with, and then looking at this phenomenon and trying to define it and what to do about it. So the concern, of course, is patient safety. This is one of the reasons, if you will, for blood conservation is, again, in terms of what we do best for our patients. So, again, overuse is associated with harm to patients. There is excess cost to society through increased cost to healthcare if you're doing unnecessary things. It defies patients' preferences. We don't know many patients who'd like things to be done to them that have risk and no benefit. And therefore, it affects healthcare quality and becomes a patient safety concern, which all of those were addressed. And when we looked at transfusion overuse, the literature reports about 40 to 60% of RBC transfusions were inappropriate, suggesting again that there was overuse, meaning you can't demonstrate benefit, all you're offering is risk. Again, if you look at the literature in terms of implementation of blood conservation or patient blood management programs, you see that there have been reductions up to 83%. In Canada, 77%, Rhode Island, 85% reduction in plasma without having negative outcome. Actually, measured outcome in patients sometimes was demonstrated to improve, and clearly a reduction in resource utilization. So again, you could see that the 40 to 60% is probably conservative in terms of inappropriate use. Confounding this problem of overuse is the variability of practice. This is one looking at observed variation in hospital-specific transfusion rate for primary isolated coronary artery bypass graft. And this is in about 800 hospitals across the United States. And you could see that there is enormous variability in transfusion or red cells. This also extended to plasma and platelets within this study. As low as close to 0%, and you could see as high as 100%. And the argument is always going to be that the patients who got transfused at higher rates were sicker than those patients at lower rates. So the question is, do we make them healthier by transfusing them? And there's no data to support that. But repeatedly, every few years, I will tell you, every 10 or 8 to 10 years, there's a large study like this one published on the variability of transfusion, having the same conclusion by the authors that the variation in transfusion rates are not due to the differences in patients' acuity. So again, there are not necessarily matched, but close to matched cohorts. And the differences, again, in this had to do, or the variation was due to differences in how patients' blood was managed, something you're looking at. Anemia treatment, we already addressed the fact that that's ignored. Avoiding blood loss and inappropriate transfusion thresholds, so-called the word trigger, as you can see, has been changed to reflect more of a medical term rather than a military or a gun-toting term called the trigger. This is not restricted to cardiac surgery. You could see the variability of transfusion occurs in all other areas of surgery and medicine. And it's repeated again in all of these trials that it is not due to the underlying acuity of the patient. So transfusion practice has been talked about for quite a while. This is a few studies that were published, first with Howard Corman in 1995 in Chest, where he said it was not scientific, And the rationale for transfusion is not well explained in any of the records. Salem Schatz from Massachusetts, when they published this in JAMA, what they showed was that people who understood transfusion medicine had the lowest rates of transfusion compared to those who had very little knowledge of transfusion medicine, which had a very high. So the more you know, the less you give of blood, the less you know, the more you give. And again, Tim Goodenhouse and others showed that it was cultural. Again, another trial looking at variability of transfusion from one institution to another and from one practitioner to another, and it was not, again, scientifically based. So guidelines that we have are either unknown to many people or ignored. This is not a new problem. You're probably familiar with this journal. This is on September 1936 article in New England Journal of Medicine. It's titled The Use and Abuse of Blood Transfusion. If you read this, it would be as if it was written in 2016. So who's the population at risk? We've been told by our beloved American Red Cross blood services that blood saves lives. Well, if it did, then we wouldn't need trauma surgeons. We just give blood. How do we explain to those who have been transfused heavily who don't survive? So again, blood is clearly recognized as part of the resuscitative armamentarium that we have, and it's an integral part of that and should be recognized as that. But in terms of survival in these situations, mostly trauma and hemorrhage, you could see that we can identify this population, which is very small on the left side of the slide, but retrospectively. On the other side, though, if you have a fatal hemolytic reaction from a transfusion of red cell plasma platelets, again, there's death associated with that transfusion. But in the middle lies this rate of transfusion across our nation of 1 to 3 units of red cell transfused in hospitalized patients. These are not hemorrhaging patients, where we cannot really assess the benefit-risk ratio. So where you cannot demonstrate benefit, all you're offering a patient is risk. But many of the transfusions between 1 and 3 units of blood or red cells are done to improve our sense of anxiety rather than demonstrating any benefit for patients. A large study that we did was funded by the Austrian government. We came up with data, and this has actually been repeated and corroborated, that surgical patients, and 94% of transfusion in this population, are due to 3 modifiable risks. The first one is coming into surgery with a low hemoglobin. Low hemoglobin meaning anemia. That's correctable. The other, of course, is excessive blood loss. And I put surgical in quotation because overall, the major blood loss for hospitalized patients comes from phlebotomy. If you ever went, at the end of the day, down to your chemistry and hematology labs to see the canisters of blood, you'd be amazed. So again, we actually withdraw 4 times the amount of blood from patients annually than we give them back. And if you start off with a low hemoglobin, the only thing that's going to change if you phlebotomize your patients repeatedly is the hemoglobin level, because the labs come back usually normal. The most common reason in these United States for phlebotomy of hospitalized patients is sunrise. It's another ritual. And again, if you cannot justify the test you're doing in terms of changing your management or making sure your management is working, there's no need to do repeated tests. And this is something we're now recognizing as a major contributor to anemia, and hospital-associated anemia, as I already showed you. And last, of course, is the inappropriate transfusion practices, which, again, I showed you the science is not there. These are all modifiable events. Now, the blood industry, just to show you the depth of their knowledge. In 1970, we had what's called, some of you are probably too young to remember, something called the HIV epidemic, which was also associated with the hepatitis C epidemic, which we're still seeing remnants of today. And the blood user, or the blood providers, the blood bankers, recognized that blood products carry a liability. It's a product liability. And a very renowned, now deceased pathologist by the name of Tom Zuck went to Congress and wanted to change blood from being a product to being a service, again, alleviating the risk of product liability, of transmission, of disease, or any kind of medical condition which is detrimental. And what came out of that was something called the blood shield laws. In the United States, blood is no longer a product, it's a service. And these are the two sentences that Tom Zuck used. The blood is unavoidably unsafe and blood is inherently dangerous. Now, this does not get transmitted to the rest of the population. But again, I think we have to be cognizant of the fact that those who provide us with the blood understand that it's our behavior that is the risk to the patient, not necessarily the product itself. So we can't blame the product, but we can understand that the product needs to demonstrate benefit to a patient because, again, all we have lists of risks. Now, the CDC was woken up to this article that appeared in JAMA in 2014, looking at healthcare-associated infections, something we're very concerned with both in the surgical and non-surgical population, and its relationship to red cell transfusion. This was a systematic and a meta-analysis review that was done. And again, what they were able to demonstrate that serious infections in patients were clearly related to transfusion of red cells. And this was accompanied by an editorial by Jeff Carson, also from New Jersey, who I cannot always agree with, especially with this title stating that blood transfusion and risk of infection, new convincing evidence. The evidence was not new. Because think of it. This is blood, which is an organ, if you will. It's a liquid organ. And each time you give a unit of blood to patients, it's actually a transplant. The amount of proteins that are coming from the donor to the recipient are not all matched. We do match ABO and possibly other antigens, but necessarily the amount of protein that we're transmitting is enormous. And immune modulation is clearly something that occurs. We generally transfuse the sick and not the healthy, which already have a reduced immune response. And now, on top of that, we're adding the insult, if you will. Well, if it's necessary, it's a risk-benefit ratio. But if it's unnecessary and no demonstration of benefit, you're now throwing all of this soup, or immune soup, if you will, into the recipient. I'm not going to go through these lists of potential risk of blood transfusion. You're probably all familiar with these, but keep in mind that the FDA still recognizes the wrong unit of blood to the wrong patient as the number one risk. So pre-donating blood actually is a practice which has gone by the wayside in most of the Western world. What we're now concerned more, again, immune-based, is transfusion-related acute lung injury, or TRALI, and TACO, which is probably the most common complication we see, is transfusion-associated circulatory overload, was thought to be completely mechanical, but now data from Mayo is very convincing that there is an inflammatory response with TACO that, again, accompanies the mechanical event. So we know that there are risks. We have to measure the risks against the benefits. So we look at the efficacy of transfusion. And what I have here is a list of authors and the different studies that were done, giving you also the variability, of course, in the size. But there's a pretty good sizable population that has been studied looking at transfusion and clinical outcome in these patients. And as you go down the list, you could see that most of the clinical outcomes associated with transfusions were negative. One Weber's trial was, again, looking at EPO versus blood, so that was not a well-structured trial, but it's there anyway. And Wu et al. In their first trial from the VA showed that at very low hemoglobin there was an improvement in survival in patients, but at a higher hemoglobin there was actually reduction in survival. And this had probably one of the biggest controversy because out of that number, as you see, and none of these were patients, these were all VA records, and some of the methodology has been questioned. 15 international experts were gotten together, transfusion experts, looking at 33,000 citations reduced to 500 citations that looked at the appropriateness, which is a Rand-Delphi methodology assessing the outcome and the benefits or risks of transfusion. And 450 clinical scenarios of hospitalized patients being transfused, except hemorrhage, were addressed. And through the Rand-Delphi methodology, appropriate meant that transfusion improved health, uncertain meant that there was no benefit, and inappropriate that there was actually harm associated with that. You could see that 88% of transfusions either were harmful or had no benefit to patient, only 12, and those mostly were in patients who had silent bone marrows or bone marrows that were not functional. What are we giving is the question. Why is there such controversy in terms of the benefit of transfusion or the non-benefit? We need to look at, quote unquote, this product, or as I mentioned, the service, but clearly it's blood component. So what's circulating in your veins and arteries is very, very different than what you're getting from the blood bank. As you could see over time, there are going to be morphological changes as well as chemical and biological changes. Some may be reversible after transfusion, but as time goes on, and in average in the United States, it's between 18 and 21 days of age that blood gets transfused. Sometimes it's as low as 14, but most of the time it's older than that. These changes are not always reversible. But at the time of transfusion, you're not going to get the benefit that you have by producing your own red cells. If the patient can produce their own red cells, the benefit is enormous. Now, this is I'm going to show you something called a cytoscan, which is a real-time, if you will, capillary perfusion Sinai. And this one shows a patient who has a hemoglobin of 3.4 that has been completely resuscitated with volume, has a normal blood pressure, normal heart rate, is maintaining well, making urine, but clearly cannot run a marathon by any means. And if you look at this patient, you'll be able to see, if I can get this to work. Yes, you can see that every capillary is perfused. The hemoglobin amount is very low. But keep in mind that it's perfusion that's needed to deliver oxygen. You can have a lot of hemoglobin on board. If there's no perfusion, no oxygen delivery. You can have very little hemoglobin on board. If you have perfusion, you will have oxygen delivery. You may not meet your needs under those circumstances, but there are ways of manipulating. So I know that even at Sinai, in my institution, a 3.4 patient will receive a transfusion. And once you see what happens with a single unit transfusion, these are aged red cells. Now what you're seeing is the capillary density is reduced. The areas where there's no movement or perfusion whatsoever, because again of these rigid cells that have been transfused, you can see that there's swelling of the capillary. The whole capillary density and the architecture has changed with a single unit. Now we know that functional density of capillaries is being associated with worse outcome. This has nothing to do with anemia. This is in septic patients, and you could see that compared to the control, reduction of functional capillary density is associated with worse outcome. And this is in, again, animal data, but showing similar in large animals, the fact that as you reduce your functional capillary density, your survival goes down. So we know that there are issues with this product. That's the only thing that we have, if you will, in terms of components. So if we're mindful of it and see that we can actually produce their own red cells, patients can produce their own red cells, it would be superior to what we get from the blood bank, and even the blood bankers will admit to that. And what they also admit to the fact is that the cost is an issue. And as you know, each time we face a new agent in the blood system, the cost of, again, retrieving the donors who are affected is significant. And it's just going to go up and up. This is just one illustration showing, as we test for more things, the cost of blood in terms of its purchase is going to rise. And I will submit to you that this will never end as long as there are new biological agents. But it's not just the cost of procuring and purchasing blood. We didn't know until 2010 what it cost to transfuse a unit of blood. And this study lasted about 7 years. and cost close to $1 million, so I can assure it's probably never going to be repeated, but it is now the benchmark. And this is activity-based costing, which is what the motor vehicle industry uses. So if you want to add 6 lug onto your wheel on a Chevy from 5 lugs, it's not just the cost of the lug, it's everything along the activity of the additional lug that's costing. So it's a very intricate way of looking at costing. And what was done here is that looked at the procurement, meaning the cost of buying blood in Europe and United States, computerized versus non-computerized laboratories. So we covered academic and non-academic. And you could see that the cost in red is about the same whether you're in Europe or in the United States. The blue bars represent the cost of transfusion. And that's anywhere from 3.5 to 4.5 times the cost of buying blood as a rule of thumb. That is a significant cost that we were not aware of before that. And then the cost of caring for a transfused surgical patient is in these orange cylinders, and you could see that compared to the rest, it is still a very high cost. The cost per unit transfused goes up as your utilization goes down, but you will reach a ceiling where, again, every place when you do the analysis, reduction is associated with reduction is associated with best economic formula that you can have for your institution. Just published as another activity-based costing, which again will never be repeated. This one cost less than $500,000 and lasted about 4 years, and looking at plasma transfusion. And again, the story is about the same, except the multiple is 10 times. So whatever you're paying for plasma, you multiply it by 10 as a rule of thumb to give you the cost of transfusing that unit. And most of this is done in surgical patients. Medical patients are slightly cheaper because when blood is ordered for them, they get it. We type and cross patients. If surgery goes without any blood loss, the blood gets returned to the blood bank, and that's that incremental cost. All of the cost analyses that have been done ignore some of these issues. The cost incurred to donors treating adverse transfusion, outcomes treating transfusion-transmitted disease, litigation, which has been relatively prominent when it comes to these outcomes, and a loss of productivity in terms of these complications and survival. These are not calculated. So we've gone now from an era where blood saves lives to now in Nature and in the Wall Street Journal, both prominent medical journals, where now we're seeing headlines, save blood, save lives. This comes from Stanford and Palo Alto, where they had a 24% reduction through the same activity you're looking at of red cell transfusion. There was a significant reduction in length of stay, an outcome we're measuring constantly in terms of patients and clinical outcomes, and more so than you could see a reduction which was significant from 5.5% to 3.3% of mortality patients who had transfused, and you could see the fall in that risk. And this is now being, if you will, published in the general literature, meaning in newspapers and magazines, so the public is starting to see this. And I can't tell you how many websites that we visit to just see what's out there. And there's an enormous amount of chatter in terms of reduction of exposure to allogeneic transfusion. So this brings me to some of the paradigm change in the thinking that we've had all along. And just to show you how the blood, which in the United States is an industry, it's privately owned compared to other nations where it's run by the Secretary of Health or Department of Health or, again, other health agencies, if you will, including north of us in Canada and across the pond in Europe and as far as Australia. The blood industry is now as recognized that they can't stay on the sidelines. So they come up with a definition of patient blood management. And this comes from the ABB, formerly known as the American Association of Blood Bank, where they say that patient blood management is the appropriate provision and use of blood, its component, derivatives, and strategies to reduce or avoid the need for a blood transfusion with the ultimate goal of improving patient outcome. So there's a little bit of patient in there, but mostly it is product-centered as compared to, again, the Society for the Advancement of Blood Management, where their definition is the timely application of evidence-based medical and surgical concepts that are designed to manage anemia. Now we've got the disease or condition model, emphasizes hemostasis, again, another condition that we can modify and minimize blood loss in order to improve patient outcome. Again, this is patient focus, and it looks at disease in terms of addressing that. And they've developed a what we call the cloverleaf approach to this, and behind each one of these leaves there's a list which will be more than one slide of activities that can be done where transfusion is listed, but in its rightful position, as low as possible on the list of interventions. So each one of these, again, can be addressed, and we are talking about red cells, which would be anemia. Now, this, again, has a list of all of the possible intervention for the different types of anemias there and how to manage it and the expected outcome. But with that, what we're still concentrating on, as you could see, and this is from a publication in Lancet in 2013, is the list of guidelines for red cell transfusions. From 1988, with the first NIH consensus conference, all the way up to 2016, because we've had it accepted to publication, and I'm guilty on sitting on some of these guidelines committees, because I think guidelines are a speedometer. It tells you what speed you're in, but it doesn't tell you how fast you can go. Because if it's a 65-mile-an-hour speed limit and there's traffic, you're going to go as fast as this traffic is going to go. So again, keep in mind, it's just a way of looking at things, but we keep asking the same question over and over again. What is the threshold of hemoglobin at which we transfuse a patient? And of all of this list of guidelines, 40% of them contain no hemoglobin as an indication for transfusion. So this quest for the holy grail of a number is going to continue because some people make a living out of it. But at the same time, I will tell you that we'll never find a number because anemia is extremely individual. And using one number to fit all in this particular arena is not going to help. And in addition to that, we're really not interested in the hemoglobin. Hemoglobin is a concentration. We're interested in the red cell mass. And red cell mass, we still don't have a way of measuring it non-invasively. So until we have one, we're still going to be looking at this. But this is a question, as I mentioned, that we ask over and over again, expecting different results. Comparing protocol, meaning other modalities of treatment, including iron, erythropoietin, and any other nutritional aspect. This came out of Hopkins, and they essentially looked at 1 to close to 4 patients for whom blood is not an option on protocol versus patients who blood is an option and were not on protocol, and compared their outcomes. And I'm just going to show you very quickly. The red are those transfused, the whites are patients who are on protocol who cannot be transfused. We've done a similar trial where we propensity match for being transfused, which is a little more accurate in terms of the comparator. But you could see again, death as well as complications favor the protocol compared to the transfused in this particular trial. This is another one that came out of Duke with Nicole Gwynn and her group looking at those patients for whom blood is not an option on protocol. Again, management of the anemia, all the conservation of blood that can be done. And here, transfusion threshold is not an issue, but it will be if you expand your program to everyone else. And they showed that there was no difference, although it was a small study. We looked at critically ill patients, about 1 to 2.5. And again, these are the sicker patients where you would think that they would require transfusion immediately. And you could see that we matched them with propensity for being transfused, not to match them in terms of the differences in the cohorts. And you could see that mortality rates were identical. And it's very hard to find patients who would be willing to be transfused with hemoglobins less than 3 to compare, but we had quite a few of the group where transfusions were not an option, and yet you could see that there was no difference in outcome. So the efficacy, if you will, of working with protocol, besides looking at a long-term outcome in hospitalized patients, is very good, or at least non-inferior or comparable. Just to talk about the issue of therapeutic options to minimize allogeneic blood transfusion, this is in cardiac surgery. These were 76 articles in a systematic review. And again, they're talking about the treatment of anemia, reducing routine phlebotomies, using less traumatic surgical techniques. Again, what they're using and what they're recommending uses topical hemostatic agents and others. But I will remind you that no matter what you want to do in terms of reducing the volume, which has been effective in terms of phlebotomy, the worst portion of it is the standing orders, which it doesn't matter how much volume is in the tube. If you have standing orders, you'll meet the volume. Now, the issue is, and why I show this slide, is that data shows that on average, patients in ICU, which is post-op, have an average of 40 ml per day removed from their circulation. All of you sitting here today, assuming you're healthy, can produce about 40 ml replacement of blood. Hospitalized patients, non-intensive care unit, are usually suppressed and can't produce maybe half of that. Those in intensive care unit, which we see, are clearly much more stressed and may be able to produce zero. So if you're going to take 40 ml a day and you can replace 40 ml a day, but you're not replacing it, you know, again, very simple equation where you're going to go with that. Again, there's other meta-analysis out there showing you, again, the fact that we're never going to have a prospective randomized controlled trial because nobody wants to be in a control group. And when people say, well, we can have Jehovah's Witnesses or patients from blood is not an option in the control group, but you can't randomize them. So we're left with looking at large data. And in the clinical arena, I think we're entering into a world today where 7 million encounters in terms of what you're doing, and then changing what you're doing and getting another 7 million encounters is going to be a lot more powerful than a prospective randomized trial of 2,000 or 3,000 patients. So again, these large retrospective trials cannot be ignored, although there are people who say that the only ones that are worthwhile are randomized prospective controlled trial, and that observational trials have a lot of bias in them. Everyone has a bias in them, but keep in mind, we can't throw observation out yet in medicine because, as far as I know, all medical conditions or diseases were derived from observation, not from randomized controlled trials. So all of medicine would be out the window if observation wasn't there. But again, you could see that among cardiac surgical patients, anemia was associated with stroke. You'd say, why would that be? Well, because we know that iron deficiency is associated with increased risk of stroke. Makes the red cells very sticky, and if you already have an underlying condition, anemia, iron deficiency anemia is a culprit. So we're learning a lot about the metabolism in anemia, or the biology of anemia today, than we ever have, and we're starting to see some of the understanding being reflected in these trials. Again, this is looking at anemia, transfusion, each independently associated with adverse outcome. You've already heard that message. This is another impact of anemia, long-term ischemic event and bleeding events in patients undergoing percutaneous coronary intervention. Again, showing that the long-term composite ischemic event, long-term reinfarction, long-term bleeding events. Again, and anemia was also associated with long-term mortality. So we're seeing all this, we're hearing all this, and we argue about this repeatedly, where all we have to really do is pay attention to these conditions and treat them appropriately. Anemia in cardiac surgery, the next target for mortality and morbidity improvement. Of a year's period, there was a significant improvement in mortality in non-anemic group. Again, you could see the percentages, but less so in the anemic group. So again, we need to address, excuse me, this condition, especially in the elective population. I try to put this on a single slide, looking at studies that evaluate the impact of blood transfusion mortality after cardiac operation. Again, you can look at these critically and show some of the deficits, but the signal keeps coming and ringing back and back again. And that this is something that we can do something about rather than just ignoring it or argue about it. So you could see that there is a risk in anemia and there is risk independently with a transfusion. And it starts in the lab. Again, very similar data. This is another systematic review showing that there is the risks are there. And when we start looking at blood conservation, we start seeing that, again, those patients where we refrain from transfusing them, and the biggest population we started working with were those patients for whom blood was not an option, such as Jehovah's Witnesses, and I will tell you that now we extend it to the rest of the population, but you can see that the reason we've done that is because they were doing just as well, if not better, without getting transfused and being on protocol than the rest. So because of time, I've sort of condensed some of this, but you could see some of the trials out there. And lo and behold, again, the STS, SCA, clinical practice guidelines for blood conservation have many, many recommendations, but again, adherence to this or actually incorporating this in practice is still extremely low. Again, same thing. I just want to show that there's many, many publications that come. We're seeing a surge of publications over the last 15 years in terms of favoring this intervention. This is one reason, which is reduction of resources, utilization, or saving of money. And again, another trial, another publication showing the same, that more conservation is better for patients in terms of outcome as well as use of resources. A structured blood conservation program, something we've talked about in this institution, reduces transfusion and costs in cardiac surgery. This is another one showing that it doesn't matter the complexity of the procedures that we're doing. You could have a reduction in every, and the ultimate goal, of course, that if you can spare the patient a transfusion, by doing all of those three modifiable risks addressed, you're going to end up with the top rung in terms of outcome. This is another hospital that adopted a blood conservation program, a patient blood management program, and showed again that they had some improved outcome, not in every area, but again, it all depends what you're measuring. We asked them to reanalyze the data, and this is what we got back from them. They showed a 60% reduction in transfusion of blood components, but what we asked them is to look at transfusion reaction, something that happens right away with a transfusion. You could see that a 67% reduction in that. So just that, in terms of patient outcome and costs, is positive. So when applying patient blood management, we know that whether you use those three conditions that I mentioned, anemia management, there's data to support that, the minimized blood loss, whether it be surgical or phlebotomy, data supporting that. And again, the issue of tolerating anemia while you're treating it, meaning not responding to the number, in terms of giving a patient a unit of blood, but making sure that you rev their bone marrow, because the retics come out very quickly if you do it appropriately, and those reticulocytes are young and eager to help, versus the old and used red cells you're giving from the blood bank. The opportunities with PBM, reducing waste, improve utilization, prevention of adverse events, improving outcome, and improve survival quality of life. You could choose any one of these to start with, or you could choose them all. But these are, again, the benefits of implementing this. Now, we've gone to one organization years ago. This was in 2010. The WHO, which is the World Health Assembly, oversees the WHO, which is the World Health Organization. And they came out with Resolution 6312, and they actually implemented a resolution patient blood management globally. Because in Chad, there is no blood system. Transfusion is not even an issue. But yes, you can practice patient blood management in Chad and, again, show improvement outcome. So it's not just the reduction of transfusion, but it's also addressing the underlying disease that we're dealing with, which, again, for red cells, anemia. Department of Health and Human Services in this country adopted Resolution 6312, but they just adopted it. We've got a lot of lip service, but nothing else. The Europeans have come on board early on. This is one editorial, but there are many others out there looking at patient blood management, and this is a call for action, if you will, through a wake-up call in terms of implementing it. And the nice thing in Europe is that the governments are responding to this, and they're now diverting dollars into patient blood management program. There's a large EU conglomerate now that is spending enormous amount of money to look at demonstration projects of PBM versus non-PBM hospitals. Even the blood industry, as I told you, is now recognizing that they cannot sit on their hands. This is just like the oil industry. We're conserving oil, profits are going to go down. If you're not part of the conservation portion of it, you're going to lose on that opportunity. And here's the ABB news, the growth of patient blood management program. There was another publication showing again showing that this is clearly a major contribution to the management of patients. The Society for the Advancement of Blood Management, you could see the URL below, has standards for programs. You don't have to reinvent the wheel, and they also have quality guide in terms of outcome measure. In Australia, the National Blood Authority has abandoned transfusion guidelines. No longer will they have transfusion guidelines. They now have 6 modules. The 6th one is not out yet on neonates, and this is all about patient blood management. These are resources. The amount of information in there is enormous, but again, they also have algorithms for everyone to address. So, in the last minute, what has it done? We have seen that we were the #1 transfuser in the world of red cells. You could see that there's been a reduction, that the American Red Cross, this is from the Board of Directors meeting, is very concerned. We're down from around 50 units per 1,000 population. This is how we compare transfusion rates, down to now in the mid-30s. That's a 15% reduction. That translates into millions and millions of dollars. And what I have below is 21 per 1,000. That is the Australian current transfusion rate. 21, which is less than half the way we were per 1,000. I don't think there are any, they have kangaroos, but I don't think we have any different diseases than we have in the United States. Population is smaller, but the fact of the matter is that there have been a very conservative transfusing community or healthcare community. And they're projecting below 19 by the end of this year. They already are below 21, by the way. So we're going to see a reduction. There may be some blips, but you could see that the impact is there. And what's important is that this impact is associated with reduction of resources, no harm to patients, and in many, many publications, improved outcome. This is a win-win for everyone. So transfusion medicine, I mentioned to you, is product-centered. Patient blood management is patient-centered. In our review committees, and you have to have one, like we do, right, from the Joint Commission, we ask, was the transfusion appropriate? And I think the future needs to be, or the present should be the question, was it avoidable? And I submit to you that with patient blood management and, again, blood conservation program, it is. Thank you.